This is KTN News.
Hello, good evening, and welcome to our continuing coverage of Matters Election 2017. My name is Joe Ageo, and this is Kivumbi 2017. This is the flagship elections program in the country. We started at 6 p.m. discussing several aspects. This particular episode focusing on health, the state of health in Kenya. And we've been talking to the people, talking to the experts. And now is that segment, that late night segment where we speak to the politicians, the people who go out there to look for your vote. Now let me set the stage here before I introduce my guests for tonight. While some experts have lauded devolution for expanding health facilities and better equipping them, others say the sector has collapsed in the last 5 years. Do you agree? But what legacy will devolution leave for the medical sector? Here is a deep examination by our in-house doctor, Mercy Korir.
The noise in the health sector has not always been that of jubilation during the Jubilee administration's 4 years in office.
As a union, we have declared that madaktari pia wanataka kulipwa kama tenda.
That marked the beginning of the longest doctor strike during its 4 years, a strike triggered by an exposed government's underbelly, money.
Was a tender advertised? The due number required by the law for procurement, was it followed? The committee to evaluate and was it competitive? Was it value for money?
Perhaps there's a chance that people may be paid and not supply. So we have clarified that.
This audit report of possible misappropriation of 5.3 billion Kenya shillings set aside for curative services and procurement of portable clinics being the center of this grilling. The dispute over the doctors' and nurses' remuneration has been one of the headaches for the government.
During my term, some unions have put pressure on the government to further increase the wage bill.
That could explain this pronouncement by the president during the 2017 Devolution conference.
We have offered these people more money than even doctors in the private sector receive.
At the State House Health Summit, Dr. Cleopa Mailu, the cabinet secretary, lauded the national government's investment in the health sector.
Over and above the budget given to counties, the government took an initiative to support counties to establish level 4 and level 5 institutions.
While the managed equipment services scheme is this administration's proud moment.
Prior to 2013, only 4 referral hospitals had such equipment. 92 hospitals across all counties have now been equipped with modern diagnostic equipment.
It still had and continues to draw criticism from various quarters.
Most of these equipments are still yet to be received by us, like the dialysis, the ICU equipment, because we didn't have the physical infrastructure.
Why is the pricing of imaging films and dialysis consumables from the supply Angelica costing about 36,000 shillings and 4,500 respectively, while in the open market they should be fetching between 17,000 and 3,000 shillings respectively?
In the 2017-2018 financial year, the Ministry of Health budget at 60 billion has 31.2 billion or 51% earmarked for development. Overall, donor financing of capital projects is at almost 2/3 at 63%. This being an issue to watch out for, considering recent withdrawal of donor support in some projects, citing unsatisfactory accountability. The budgetary allocation to health is still a distance away from the Abuja declaration of 15%. In total, health expenditure is around 7%, the national budget at almost 3%, while county health budgets average 32% as per the 2016-2017 budget. But plans for the future are grand.
We shall establish regional centers of excellence, and this is where cancer comes in, kidney transplant comes in, apart from establishing a regional hub referral system.
A grand future that requires tangible financial commitment. Dr. Mercy Korir, KTN News.
All right, a very detailed diagnosis there by our in-house doctor, medical correspondent Dr. Mercy Korir, looking at the health sector, looking at devolution, basically setting the stage for our discussion here. And tonight, we'll be speaking to two gentlemen, both of them members of the Parliamentary Health Committee. Both of them understand this medical profession because they're members of it, and both of them very well versed with the questions at hand. And I'll start with Mheshimiwa Leonard Pokose is the MP for Endebess, was elected on URP, but now it's all Jubilee, is it not?
Yeah, it's
all right. So he's also the Vice Chair of the Parliamentary Health Committee.
The name is Dr. Robert Pokose.
Dr. Robert, not Leonard.
Not Leonard,
my apologies.
Okay, good evening,
Dr. Robert
yes.
Pokose. Dr. James Nikal, also a member of the committee, MP for Seme.
Exactly.
Thank you very much. He's also a former Director of Medical Services, former PS, pediatrician by profession, and so on and so forth. So, gentlemen, devolution, that is where we must start our conversation. Some people say it was a good idea, badly implemented, but some people we've been listening to, like on social media, basically say it was a bad idea. Let's get this thing out of the hands of the governors and bring it back to the national government. Your thoughts? I know you will tell me about the health bill, but let's talk about where we've come from.
Thank you, Joakeo, and thank you for hosting us in the KTN News. The issue about devolution of health, I don't think it's a bad idea. When you look at it, this is actually, it's a great idea, but not well implemented. That's how I look at it. Because devolution means they were taking services closer to the people. And it was meant to take the health services more closer and available to our citizens. The only challenge was how it was implemented. And the question for us should be...
What's that? What do you mean how it was implemented? How was it implemented?
When you look at it initially, in the act, in the constitution itself, when you talk about health being a default function, where you are talking of on the fourth schedule, which are the health, you're talking of health facilities, county health facilities, you're talking of ambulance services, you are talking of chemists and also pharmacies. When you talk initially, before devolution, the Ministry of Health was divided into two: Public Health and Sanitation, and also Ministry of Medical Services. The Ministry of Medical Services was running sub-district, district, referral, and national hospitals. The Ministry of Public Health and Sanitation was running promotive health care, which is, you talk of the community health strategy, which was supposed to be under the Ministry of Public Health and Sanitation. It was running the dispensaries. It was running the health centers.
Yeah.
Now, when it came to conceptualization of devolution, these are the services that initially should have actually gone to the county governments.
So you're saying it
them.
is not clear, because I've heard you say before that health facilities as conceived in our devolved structure are not clearly defined.
Yes.
Yeah.
Yes. So what happened is when we now talked of devolving health services, the governors demanded that those facilities that were within their counties should belong to them.
So I'm going to come to you, Dr. Nikal, in a moment, but you seem to be saying that someone bungled the devolution of health somewhere.
Yes.
Who is that?
For one, the governors who are hungry to have these services, these facilities within their areas of jurisdiction. And then two, the management by the transition authority. It was the transition authority never managed the process in a proper way.
But Dr. Nikal, do you agree that devolution was a good idea but badly implemented with regard to health?
Simple. Devolution is a good idea. The implementation was badly done. And
do you agree it is the governors and the transition authority?
Basically, it is the governors, the Council of Governors that actually put pressure. But I think the national government cannot escape this because they were in the process. But the basic issue here is that we did not devolve the health system as we had planned. Actually, the whole of devolution, there is Schedule 6, which clearly stated how you should devolve every function, including health. And we gave ourselves a period of 3 years when you were to look at what capacities do counties have.
That's 2010 to 2013.
Yes.
And what happened?
And
what did we not do?
That Schedule 6 actually gave rise to the Transition to Devolved Government Act, which gave rise to the Transition Authority. This was put in place, but instead of unbundling the functions, costing the functions, and looking at the capacities at the counties to take up these functions under the supervision and the support of the national government, it was just taken one day. The unbundling was being done as they had already been given.
So
the costing was not properly done.
Why was that the case? I mean, with hindsight, surely you can see who dropped the ball.
With hindsight, I think the pressure on the national government was too great from the Council of Governors, and they actually twisted His Excellency the President. You will remember at one point the President literally threw up his hands and said, "Take everything." That was the time we lost it. There was great need to do this meticulously, because health is a complex function, very complex in terms of the human resource, very complex in the terms of infrastructure, very complex in terms of equipment that you need to put in place, and very complex in terms of the human resource, how they are trained, how they are employed, how they are transferred, how they retire, how they get promoted.
No, but many people would say, Dr. Pokosi, that the doctors and nurses were not necessarily doing that well, even when health was in the hands of the central government, as it was called back then. And then suddenly, with all the complexities that you talk about, we throw it to the governors. I mean, never mind that you say they were demanding for it, but we knew that they did not have the capacities, the counties, to deal with all the complexities that come with managing the health sector, especially with all the changes that would have come with that devolution. Did we underestimate something?
You know, as a country, we've come a long way. When you look at the number of doctors, number of nurses, and other cadres that were trained before that, let's say, come to 1970s, 80s, 90s, and progressing forward, you will find that the number has been increasing. Even when you look at the number of graduates that graduated during Dr. Nyekal's time, there were less than the number of graduates that graduated during my time. I was a medical superintendent. I'm a surgeon by profession. I worked in Baringo. And you'll find that, and working in those circumstances, you'll find that we are facing challenges, because you would be a surgeon maybe in the whole county alone. And when you are there, you have to even improvise in terms of equipment that you're going to use. Now, with the coming of the counties, we expected that it will become much easier, so that it was a well-thought idea on what we devolve to the county governments and what remains in the national.
Mheshimiwa, just hold that thought, because I want us to speak to Dr. Wilfred Machage. He chairs the Health Committee in the Senate. And Dr. Machage, you are on record as having said that you're one of the people who had some problems with the whole idea of devolving health at the beginning. Probably your views may have evolved over time, but you are on record as saying that you had misgivings about the whole concept of giving health, the management of it, to the counties. Am I right?
Yes, you are right. Remember, the draft of the current constitution was hurriedly really discussed and not really thought of properly. I had my own issues with lots of clauses in that draft. And indeed, I did oppose the draft of the current constitution. And one of the issues that was in my mind was the management of health services, agriculture, and education.
What specific concerns did you have with the management of health services?
Health services, as you know, is a professional, highly professionalized department in the government, and the per capita availability of staff in the whole country is not evenly distributed. Most of the doctors are usually in towns. We have only about one doctor to a population of about 17,000 Kenyans, but skewed to towns. Therefore, the management of training, the management of transfers, the management of salaries was going to be an issue unless these things were centrally managed.
Why was it going to be an issue? Is it a capacity of those counties? Is it that the doctors would not like it? Why did you think that the counties would not manage the issue of doctors and all the other medical services involved?
Indeed, you have mentioned the two important facts. Not all counties are equal in resource availability. Some counties are going to be more able to pay doctors than others, and especially so if you consider only resources from those counties to manage that kind of personnel. But the training has to be monitored, and that has to be centrally governed, and especially so when you come to look at the scheme of services, which has to be properly balanced in the whole country. Otherwise, other counties are going to have a better scheme of service and manage their services better than others, to the detriment of the medical services of other regions.
And finally, Dr. Mashage, 4 years down the road, do you think your fears have been vindicated? What would be your diagnosis, if you like, of the health sector this 4 years later?
Indeed, it is poor, but okay, we have to respect that we did actually pass the Constitution, and we have now to use the Constitution that is available to try and see what we can salvage. And indeed, we have come up with a health bill, which, if indeed assented to by the President, it is addressing most of these issues that have appeared as a transition problem. I believe the bill, if enacted to an act, will address and try to balance the whole issue. And it's not a bad idea to have medical services in the countries, yes, but the new law will harmonize the services.
Do you believe that the new law will solve all the problems? Or if someone came down the road and said, well, I'm pushing for a referendum or something to return this to the national government, that you would not support that? Would you support such a move?
I would be the first to support.
All right. Thank you very much, Dr. Wilfred Machage is the chair of the Senate Health Committee, speaking to us about devolution of health. And gentlemen, Dr. Machage says that this was a bad idea. What we are trying to do right now is just to make the best out of a very bad idea. Dr. Nyikal.
You started by saying that even before the devolution, there were problems in health. But actually, between the period of 2003 onwards, there was actually a remarkable improvement in the health sector, going by, first of all, just the availability, say, of drugs, the availability of staff, and there was a lot of input. In fact, that's the first time that we went up to about 11% of our budget. And that has been vindicated by the health indices from 2003 up to about 2008 onwards. I still say that this was a good idea. It is basically the implementation. We have just talked about what was transferred to the counties, and what then is the function of the national government. The function of the national government was to look at policies and standards and do the national referral system, which is about pre-hospitals.
Let's talk about
let me talk about that, because that is
because that's how I wanted to talk about how well or otherwise the national government has played that role of taking care of policy training as well as the referral hospitals. How well would you say that the national government has played that role?
That is, in my view, one of the areas that has failed, because when we devolve, there are many people who think that we now devolved and this is a different country altogether and that there's no link with the center. It is the link with the center at the national government, which was policy and standards. And had we done our devolution properly, then we would have set standards, we would have set policies, so that all the county governments would then have clear standards on how to do it and what to do. That did not take place, and that is why, even though we can say overall health has not done well, you find that certain counties have done pretty well. Take Makueni, for example, take Marsabit, Kisii, but mainly one hospital. Now, that is happening because now that is dependent on having probably a good governor and a good health director. But if we had standards, and we then could say...
So Dr. Pokose, standards, would you say the national government has played its role in so far as the devolved structure is concerned, because the Constitution was very clear about what roles the national government would play vis-a-vis what was devolved to the counties?
Thank you. I think the major problem is disharmony between the county government and the national government. Because when you look at it in the Constitution, the national government is responsible for standards, responsible for policy, responsible for national referral hospitals. Apparently, there's been a bit of, you'll find that when you look at many of the governors, occasionally they complain that the national government has a lot of money, while there is very little money within the county government. When you look at the budget for health, I think there is a lot of misinformation outside there. The budget of health, for example, for this financial year, you're talking of about 61 billion. But when you look at that budget line for the 61 billion, 28 billion is money from the donors, which is going to purchase the vaccines. It is going to HIV/AIDS management. It is going to other programs that are supported within the immunization
so you
programs.
don't agree, obviously, with people who say, well, the national government still has this huge budget,
I don't think they understand. They don't understand what they are talking about. Because when you look at the line items in terms of what is that budget, and then actually you'll end up with about almost 33 billion. That is the actual money.
But there's been criticism that the national government meddles a bit too much in health in the counties.
Yes, I'll come to that now.
Veering into areas that they are not even
I'll
supposed
come into
to.
that.
Yeah.
So you'll find that the national government now, from the real budgeting, from what comes from the government, is around 33 billion. That is the total budget that goes to the Ministry of Health at the headquarters. Out of that, some of the money will go into Afya House, others will go to spinal injury, others Madare, you're talking of Kenyatta National Hospital, you're talking of Moi Teaching and Referral Hospital. That is distribute now the other 33 billion. Then the rest will go to vaccines and other programs which are still being run at the county government. Now, what has happened is that when you look at the staff at the headquarters of the Ministry of Health, you have a bloated staff. A bloated staff.
Why?
That is not that people now start to create programs to run themselves and departments. Instead of, these are the people who should have actually been devolved.
So you have more people than you need.
You don't need all that stuff in the Ministry of Health.
Dr. Nyika, let's talk about the money. Dr. Pokose says that the money that is left, as people would like to say, with the national government is just enough, perhaps not even enough.
Well,
because the counties get probably
he has gone ahead and actually made a very important statement that probably we have more people at the headquarters than we need. If you take that into consideration, then the emolument,
should get these people out and reduce the money.
The emolument that go with that is definitely excess that would have helped. But why has that happened? And that's the point I was coming to. That has happened because we have not clearly stated we are doing policy, and these are the policies.
So who is this we that has not stated?
We is the national government. And obviously there is an intergovernmental relations arrangement that when they are making policy, there needs to be consultation with the county government. because you are making policies that others will follow, you involve them. These are therefore the standards. Once you do that, then really you have very little to do in terms of programs. As saying, the programs can then be run by those at the county, but they are doing them.
But isn't it public knowledge that there has been reluctance by certain people at the national government to to let go of certain things, and that might explain what you're talking about? Is that
even if that
I've
was
had this
even
discussed
if
by a
that
lot of
was so,
medical,
even if that was so, and I can't say I know who in particular is against it, even if that was so, we played into their hands by doing it so abruptly that now we didn't let systems be checked and worked into. So, and then there's another element now. When we talk of standards, when you look at even human resource, you will need standards. The commodities, drugs, you will need standards. Even buildings, you will need standards. So if you are treated in Migori, you should be expect exactly the same treatment as in Nijara, even if they're being done by different countries. But now, do we have a situation where we've said this is the standard, and somebody can have some arrangement where you look at the county and to say, County A, you are doing very well, but you need to have so many staff for this level, and you actually have this. And that person need not enforce that and look like a policeman, but bring it to the notice of the county health executive and then probably the governor and say, we are short here because we need that. And that will improve even the financing of health at the county level. Right now, my colleague will tell you, we have even said, we have even given conditional grant to go and support the level 5s. And when we go around to look at it, you don't find that this conditional grant is being used in a uniform manner across all the counties.
In fact, just on the conditional grant.
We will pick it up from there. We want to take a short commercial